Consider the following vignette. A 34-year-old woman presents to the ED with a first-time seizure at home. By the time she gets to the ED, she is back to her neurologic baseline and otherwise has a reassuring exam. On review of systems, she reports that for the past 6 months, she has had these intermittent, dull, tension-type headaches that she had attributed to increased stress at work. The ED staff has already gotten a head MRI, with the flare sequence showing a mass in the left frontotemporal region. You are concerned that she has a low-grade glioma. Neurology has already started her on levetiracetam and informed her that she has a mass in her brain. As you walk into the room, you find an emotional patient who has many questions for you. You explain the plan for resection in the OR in the coming days. However, her main concern is the seizures. She recently had a friend who had a brain tumor and experienced how much her friend's quality of life had changed after having epilepsy. She asks, "Why am I getting seizures now? Will I have seizures forever? And is surgery going to help address the seizures at all?"
Hi, my name is Ariel Sanchez. I'm a third-year medical student at the Perelman School of Medicine, and today I'm talking about brain tumor-related epilepsy and gliomas. This work was inspired from seeing the prevalence of seizures in the Neurosurgery tumor service and wanting to understand the underlying research. The goal of this talk is to provide a broad overview of our current understanding of the molecular and network-wide changes in brain tumors, and more specifically in low-grade gliomas.
First, it's important to point out that epilepsy is not equally distributed amongst the many types of brain tumors that exist. A meta-analysis done in 2022, which looked at over 20,000 patients with brain tumors, found that low-grade gliomas by far have the highest prevalence of seizures, at over 63% of patients having them, compared to 34% in glioblastoma, 24% in meningiomas, and only 12% of patients with brain metastases having seizures. And it's important to note that this data is a summary of a vastly heterogeneous collection of low-grade gliomas. Other data suggests that up to 90% of patients with diffuse low-grade gliomas have epileptic seizures. This data is important because it informs the overall management of these patients once the brain tumor is discovered, especially if seizures are not a presenting symptom. According to the American Association of Family Physicians, for example, the most common presenting symptom of all brain tumors is bilateral tension headaches at 56% of patients presenting with that. Only 32% of patients first present with new onset seizures, so understanding which tumors tend to have higher seizure prevalence informs further seizure workup. Additionally, knowing that 60% of low-grade glioma patients will have seizures guides physician decision-making on anti-seizure medication management. The International League Against Epilepsy defines epilepsy as either 2 unprovoked seizures or a first seizure with the probability of having a recurrence risk of 60% over the next 10 years. Therefore, knowing a patient has a low-grade astrocytoma is important in informing decision-making going forward about anti-seizure medications. This work matters quite a bit to patients given how much it impacts their quality of life, oftentimes more than the tumor itself. There are also other things to consider. Recurrent seizures can contribute to neuronal dysfunction as well as cognitive impairment down the road. Additionally, as we will discuss, since tumor-related epilepsy can arise from multiple interacting mechanisms, it is often more resistant to standard anti-seizure medications. There is also the added risk of polypharmacy in the setting of adding on these agents at a time where patients are undergoing other treatment modalities like radiation therapy, chemotherapy, and other cancer-specific treatment. So managing tumor-related epilepsy is challenging because clinicians must balance seizure control with the risk of polypharmacy and concurrent cancer therapies. What I'm going to do for the rest of this talk now is to discuss our current understanding of what causes these seizures. I broke this talk up into 3 major categories of changes surrounding gliomas that create an increasingly hyperexcitatory environment that predisposes to seizures. As a disclaimer, the true cause is likely an interplay of all of these mechanisms, among others, but to date, the mechanisms are not fully understood, partially because of the complex changes in the vast heterogeneity of brain tumors. Before I proceed, it's best to first recall that seizures can be best thought of as disruptions in the balance of excitation and inhibition. The changes we will see highlight either decreases in the brain's ability to inhibit signal or increased excitability within the tissue itself. With that being said, the 3-part framework I've chosen to include are the following: tumor intrinsic and molecular factors, the tumor microenvironment, as well as the peritumoral network changes. And we are first going to start by taking a look at the tumor-specific changes that predispose the brain to seizure. Multiple genes have been implicated as independent risk factors for increased seizure susceptibility. These can be thought of in a few buckets of major changes within a tumor that promote epileptogenesis. The accumulation of neurotoxic metabolites are one example of these changes. When the gene isocitrate dehydrogenase 1 is mutated, for example, this leads to the increase of D2-hydroxyglutarate, a molecule structurally similar to the excitatory neurotransmitter glutamate. Relatedly, brain cancers, like other cancers, are found to prefer the use of aerobic glycolysis, a phenomenon known as the Wahlberg effect, leading to the accumulation of lactate within the tumor. Changes like these increase the levels of neurotoxins that can cause neuronal dysfunction. Additionally, pathways like the mTOR and RAS pathway have been implicated in tumor progression and likely play a role in promoting abnormal growth of glioma cells. These alterations likely contribute to the creation of improper neuronal synapses and disruption of the normal balance of excitation and inhibition. Interestingly enough, some studies have even shown that the accumulation of D2-hydroxyglutarate appears to activate the mTOR signaling pathway. Other studies have also shown that mTOR can be activated from subsequently acquired mutations in the tumor in genes like the P10 and TP53, to name a few. Additionally, changes that have been found include changes within astrocytes themselves. The astrocytes are important in maintaining electrolyte balances in electrolytes like potassium. Some studies have found that when the Cur4.1 potassium channel found in astrocytes is mutated, this may inhibit the ability for potassium to buffer neurons, which leads to production of seizures. Additionally, previous work has also shown that gliomas specifically express this XC cysteine glutamate antiporter system. It's thought to be an adaptation that allows tumors to react to the stress of reactive oxygen species by creating glutathione. A byproduct of this is the excess glutamate in the surrounding environment, which increases neuronal excitability and promotes seizures. Additionally, the increased glutamate is toxic enough to kill surrounding neurons, opening additional space for tumor expansion within its particular microenvironment. Now we're going to take a look at the changes within the environment surrounding the tumor. These are changes related to the ways the presence of a glioma significantly alter the balance of excitatory and inhibitory signals. First, the growth of the tumor harbors a local inflammatory response. There have been so many cytokines implicated in brain tumors that we won't have nearly enough time to cover them here, as this would justify its own separate talk. The overall picture is that this inflammatory response, mediated by astrocytes and microglia, harbor changes that lower the seizure threshold, as well as produce oxidative stress within a local environment. Additionally, other studies have found that cytokines, including TNF-alpha released by microglia, may increase neuronal glutamate release while reducing GABA receptor function. Other research has also shown that another important aspect that may be that gliomas disrupt normal glial cell function in the peritumoral cortex. Specifically, previous work has shown that peritumoral astrocytes may become more reactive and as a result lose their ability to clear the extracellular glutamate. This may be related to the downregulation of high-affinity transporters like GLT1 and GLAST. Additionally, research has also suggested that cytokine-driven inflammation may contribute to inhibitory interneuron dysfunction and loss, further shifting the balance towards a more excitable state. A third related change relates to a few earlier points. The accumulation of neurotoxic metabolites and local inflammation produces a stressful environment that taxes the glial cells and leads to overall glial cell dysfunction and excitotoxicity. Taken all together, this produces a heavily excitatory environment with few GABA receptors and inhibitory mechanisms left. This image here, taken from an article from Dantio et al., demonstrates many of the mechanisms that we discussed here, as well as others, and are taken from an excellent review article on this topic for further exploration. This last bucket of changes that predispose to brain tumor epilepsy involves the network changes that are consequences of tumor proliferation and integration into the cortex. It has been found that both the inflammation we discussed in the previous slide, as well as tumor-related proteolytic activity, together may contribute to breakdown of the protective perineuronal nets surrounding inhibitory interneurons. This leads to the dysfunction of key inhibitory signaling that shifts the balance towards excitatory. Additionally, GABA signaling is significantly impaired within the peritumoral region. This is likely a consequence of the changes we touched upon earlier regarding changes in the electrolyte balance and receptor availability. It is probably evident that as gliomas continue to grow, they integrate directly into the brain circuitry and become a nidus for potential future seizure activity. However, recent work now suggests that neurons may further promote the integration of gliomas into neural pathways. It is thought that within this excitatory context that is created, neurons secrete key molecular factors that promote glioma progression and integration of connections into the neural network, or so-called synaptogenesis. The changes we previously discussed contribute to the functional remodeling of local and distant neural circuits. These changes alter the interaction between neurons and the surrounding glial cells, promoting seizure activity. We'll explore this idea further in the next slide. With the help of newer resting state functional MRI, we are starting to see the extent to which gliomas change the landscape of the pathways within the brain. This work has looked at diffuse gliomas, which migrate preferentially along fiber tracts. These studies show that, in fact, the greatest changes are not necessarily in areas physically juxtaposing the tumor, but are in fact the areas that are strongly connected to the tumor functionally. This work may help to explain why the neurologic symptoms that patients develop over the course of their illness may differ from the anatomical region of the tumor. Such studies also suggest that brain tumors wage an ever deeper assault on the brain than was previously thought. Now, as we are discussing the epileptogenic changes within gliomas, one emerging area within the tumor-related epilepsy space is using connectomics to have a bird's-eye understanding of glioma progression and understanding the patterns of glioma growth. Newer research has found that gliomas preferentially develop in areas with high cortical activity. One of the potential explanations for this is that these areas are under increased metabolic demand, and as a result are also under increased oxidative stress, which may make them more susceptible to oncogenic transformation. A recent retrospective study looking at where low-grade gliomas and high-grade gliomas clustered had a few interesting findings. First, these tumors have high anatomic heterogeneity, with high-grade gliomas preferring frontal and parietal lobes, while low-grade gliomas cluster around the frontal region. However, both strongly preferred highly connected nodes within the brain, clustering around some of the most highly connected areas, like the ventral attention network. This paper has some excellent figures that demonstrate the highly connected areas that are most affected. Just a quick bird's eye view in this figure, we note that the highest frequency cluster around more central parts of the brain. These areas are highly important during surgical resection, as these hubs are critical for cognitive function. And as we discuss in the following slide, these findings have important implications in planning for surgical resection. Knowing that gliomas will closely align with key connection hubs, the goal will be to preserve these critically active hubs as well. At this point, I want to briefly connect what we discussed back to what inspired this talk. How does this all inform the higher level goals that neurosurgeons have when planning surgical resection of gliomas? Emerging technology like resting state MRI has changed the goal of tumor resection from simply removing the maximal amount of tumor to balancing tumor clearance with preservation of functional networks. Mapping helps identify critically eloquent structures such as language, motor, and somatosensory areas. Awake craniotomies enable surgeons to test these functions in real time, allowing for maximal safe resection while minimizing functional loss. With that idea in mind, tumor resections in awake craniotomies allow neurosurgeons to identify in real time potentially epileptogenic zones, particularly in the peritumoral area. Resecting these areas can improve seizure outcomes without compromising function. As is apparent from the previous slides, the brain of these patients are incredibly hyperexcitable. Awake mapping and intraoperative monitoring help surgeons avoid stimulating seizure-prone regions, and if seizures do occur, allow for efficient real-time management. As we wrap up this talk, it is clear that glioma-related epilepsy remains an area with major opportunities. Each component contributing to tumor-related epilepsies, shown here, offers a potential target for future therapies. Advancing these therapies may help us improve seizure control and the quality of life of patients with brain tumors. For example, research is currently being done to understand how targeting glutamate receptors can suppress glioma growth. As previously mentioned, glutamate has been implicated in activating pathways of the mTOR pathway, so research is being done to understand the receptors found on tumors to control glioma growth. This could be a very promising target, since excess glutamate facilitates the epileptogenic environment. Another promising area is using patient-specific network mapping alongside current molecular and genetic profiling to tailor interventions that minimize seizures and maximize functional preservation. This points towards a future with clear strategies for individualized patient care. Thank you so much for taking time to listen to my talk. References are listed here, including several excellent review articles and primary studies for further reading.